Okay, starting lecture number 5. We are finished talking about anesthesia, and now we're talking about when we wake the patient up. A lot of people believe that all of that waking up takes place in the recovery room, and while what the patient remembers is likely to be the recovery room, we actually start the process of waking them up in the OR. Many times when we leave the OR, the patient is already extubated. We've been able to have, say a few words with them. They've been able to follow simple commands. They're still very sleepy, but they are arousable. So when we get them into the recovery room, obviously recovery is going to entail constant supervision. Most recovery areas are kind of like a bay, and in that bay you might have 2 or 3 areas that you're responsible for. And while you can pull a curtain to separate them, there should be a place that you could stand and literally see all 2 or 3 of your patients. That would be the absolute max. Normally 1 to 2 patients is a typical patient load in recovery. We're going to do frequent vital signs. This includes pulse ox, and it also, for the recovery room nurse, also includes, charting and watching their cardiac monitor. So they're going to chart whether they're in normal sinus rhythm or sinus tach, or what's going on. But we do the first 15 minutes we're in there, we're actually going to do Q5s for 3 times. So Q5 times 3. Then we'll go to Q15 times 4, Q30 times 2, Q1 hour. Just depends. It may only be for 4, and then we go to Q4 hours, but if the patient has a PCA pump, that Q1 hour stays for much longer because of that PCA pump. We are going to be, assessing and documenting their level of consciousness. Please remember here, patients who are given amnestics will often ask questions repeatedly, especially if they had something very concerning that they were having surgery about. Maybe they had a biopsy, and maybe the doctor, said something to them right after the surgery, but of course, they don't remember it. Something about, they sent the biopsy down, but, basically what he looked at, he thought it looked really good, didn't see anything suspicious, and the patient's like, oh, okay, great, yeah, that's wonderful. And then they fall asleep, they take a little nap. When they wake up again, it's like a brand new day. And they don't remember any of that prior conversation. So they're going to have that initial panic of, oh, well, did he say anything? What did he find? And you're going to repeat what the doctor said, and then the patient's going to seem calm, and they're going to say, okay, and they're going to fall back asleep. And 5 minutes later, they wake up, and it's a brand new day. So understand that that's going to happen for the first several minutes that they're in recovery until that amnestic really starts wearing off. Then you'll start to see them go, oh, wait a minute. We talked about this before, didn't we? And you're like, yeah, but the medicine's making you a little fuzzy. It's no big deal. But you can start picking up on the fact that the amnestic is wearing off because they're starting to at least recall that the conversation had been had already. Our biggest worry in the recovery room, for obvious reasons, is airway. So most of the time we're going to manage airway by positioning. In fact, the easiest way to manage your patient's airway is proper positioning. Unless it is absolutely contraindicated for the type of surgery that they had, most of the time in the recovery room, we are going to have the patient in a semi-Fowler's or low Fowler's position. At least a 30 to 45 degree elevation of the head of bed, because that elevation helps with breathing, it helps with the work of breathing, it also helps with the airway. Very few instances would that be contraindicated. Maybe if they had spinal fusion, and you wouldn't be able to sit them up. But a lot of people think that if somebody's had a spinal anesthesia or an epidural, that they can't sit up. That is completely bunk. There is nothing about having a spinal block or an epidural block during surgery that precludes them from sitting up. The only thing that would do that is if the doctor, if they did some type of lower spinal fusion and the doctor just absolutely said they had to lay flat in bed, well then obviously you can't elevate the head of bed. Level of consciousness is going to, like I said, kind of fade in and out, but here's the thing. The quicker they blow off the anesthesia gas, the faster their level of consciousness improves. So Nobody loves having an O2 mask on after surgery. In fact, sometimes they'll be a little confused and they'll want to take it off. But what you have to understand about oxygen is oxygen displaces the anesthesia gas. And you'll be able to smell it too. If you're right up next to the patient and they're talking, their breath is going to have almost like a chemical smell to it, and that is anesthesia gas. And if their breath is smelling like that, that is telling you they still have quite a bit of gas to blow off. So the longer and better you can keep that oxygen affixed to their face, the quicker they're going to displace that anesthesia gas with O2, improving their oxygenation, but also improving their level of consciousness. Also, there's always a risk of emesis. I mentioned before about those inhaled anesthetics. They increase the risk of nausea and vomiting. So having their head elevated is also going to help us with that. Of course, if your patient is nauseous, you want to leave the head of bed elevated, but you would prefer to turn them on their side. So if, they would start to retch or something when they are still, half asleep, they don't accidentally aspirate that emesis. You should always have O2 available. And like I said, even when you go to the floor, just about every patient who's had a general anesthetic is going to need some O2 for a little while. And you should also have suction available, because suction can get you out of a pickle if a patient is, not completely awake and they're still, trying to throw up. So like I said, semi-Fowler's and less contraindicated, but the other thing that you're checking, and it's almost like, I'm not going to say you do everything with vitals, but along with the vital signs, you're going to just do a quick wound check. A quick peek at the wound, a quick peek at the dressing, just to make sure all is well. You're not taking the dressing down, you're not doing anything crazy. It's a quick peek. But it's that whole idea of, well, keep an eye on them. Well, you can't keep an eye on them if you don't actually look. So you need to check the wound, eyeball the drains and tubes, just making sure that, if a drain is like say a JP drain, and it's got very tiny amounts of serosanguinous, the clear, red looking fluid, and all of a sudden that drain picks up and it's half full of very dark red blood, a little red flag ought to be going off, or little alarm bells ought to be going off in your brain thinking, I'm supposed to be getting excess tissue fluid in this drain. I'm not supposed to be getting the result of actual bleeding, active bleeding. And so if that starts happening, that's definitely probably going to warrant a call to the physician. So while you're not going to go crazy with everything and probably document everything every time you do vital signs, when you're in there doing vitals and you're waiting for, if it's a machine blood pressure cuff and you're waiting for that blood pressure cuff to do anyway, that's a great time to just peek at everything. Look at the dressing, look at the drain, check the Foley, boom, done. How easy was that? IV maintenance, we're going to talk for a minute about the reasons for IV therapy. Obviously, Med-Surg 2, we are going to get into this in great detail. But for right now, we just need to understand that the IV fluids that the patient is getting is first and foremost replacing fluid. Maybe because of the fact that they were NPO, maybe because of the amount of blood that they lost in the operation itself, but we need to replace that fluid. Then it's also providing electrolyte replacement, attempting to bring them back into a normal balance after, we've done all this crazy stuff with surgery and everything else. But it's not just about the fluids that are administered. Having an IV gives us direct access to that patient's venous circulation. And if you recall what I said about, the propofol, when we gave that for induction and how the patient probably would barely count to 3 and they were out, I hope that gives you some measure of how quickly a drug given IV hits the systemic circulation. It's not like an IM where you give that IM and it could be 15 minutes or really even 30 minutes depending upon the perfusion of the muscle before you see the full effect of that drug taking place in the patient. With IV, it's seconds. This is not something that, you want to kind of blow off. This is a big deal. But the nice thing about that is if we do need to give them something, it allows us to give them very rapid action medications. In fact, patients will get to the point where they don't want to go off their IV pain medication because they know the second they push the button or the second you come in or the RN comes in with that syringe and they put it in their IV, they just start immediately feeling better. But just like anything else, if it acts rapidly, it goes away rapidly. So they don't get much longevity with those medications. Whereas when the time comes when we can get them transferred over to orals, yes, it might take 15 to 30 minutes for that oral to actually kick in and for them to see any real benefit of it, but they're going to get a solid 4 to 6 hours of relief instead of, every hour going, oh geez, here it comes again, here it comes again. The other point with the IV is to have an option for nutrition. Now, in the very most basic level, yeah, there's some dextrose in a lot of IVs, and it's going to give you a few calories. But the dextrose in an IV bag is very low percentage and is not going to provide full nutrition. It's basically just providing sugar. And sugar, I hope we have realized at this point, does not a complete diet make. So clearly we need proteins and we need fats and everything. So if we know the patient is going to be NPO for a while, or maybe they have been NPO and are still going to be NPO for a few more days, sometimes the doctors may choose to put in a central line for their IV access and then put them on TPN. Now we will go over the ins and outs of TPN in greater depth in IV therapy, but suffice to say that TPN and lipids offer up the amino acid building blocks that we need for protein building in the body, and it provides the fat required to cell build, because remember, every cell membrane is made of fat, so you actually do have to have fat. The risks of IV therapy, please remember that there is an IV therapy hazards handout on your Canvas site. It is assigned material, it is testable material, and I will expect you to read through that. Now, some of it is going to be total common sense, and you're going to go, duh. But some of it, I hope, makes you think for a minute and apply what you know already to this, whole IV therapy situation. We don't learn in depth about IV types in MedSurg 1. We will do that more in MedSurg 2, but it is an expectation that you can recognize the different types of fluid and that you can tell whether or not the right fluid is hanging on your patient. Normal saline, NS, that's how we talk about normal saline, and that's how nurses talk about it. We don't say 0.9% sodium chloride solution, but that's what the bag is going to say. So you need to be able to recognize that normal saline is 0.9% sodium chloride solution. So therefore, half normal saline, do the math, is 0.45% sodium chloride solution. D5W is 5% dextrose in water. D5.5 normal saline would then be 5% dextrose and 0.45% sodium chloride solution. So it's going to be all mixed together. Lactated ringers and ringers lactate are the same things. Whether somebody says LR or RL, they are the same. But those are some very basic fluid types that you do need to be aware of. We also need to understand what's going on with blood and blood products. And while in MedSurg 1 we will not be administering blood or blood products, that doesn't mean that you can't monitor. If someone else has got the IV going and they're administering the blood, you can monitor for transfusion reactions. So we will discuss briefly transfusion reactions in this unit, and you'll get it again. You'll turn right around in hematology and get it again because you need to know that. And then you know what? You'll turn around in IV therapy and you'll get it again because this is important, and it is something that you need to be well aware of, and it's definitely something the board likes to test on. So what are your nursing responsibilities for the IV right now? Right now it's monitor the site. You should know what normal skin looks like for your patient, and where that IV is going in, it should look like normal skin. It should not be puffed up, it should not be highly bruised, it should not have a bunch of fluid leaking out of it, it shouldn't be freezing cold to the touch. So if all of these things are sounding familiar, that's amazing because you probably then have read your IV therapy complications handout. There are a bunch of definitions on that handout. If you pay no attention to those definitions between now and test day, you will be very upset with yourself when you get to those test questions, which should have just been easy because they were puking back basic knowledge, but now you're trying to guess because you didn't look at that handout. Other things that we're supposed to look for, we're supposed to prevent infection. You should know that an IV site dressing needs to be intact, and if the dressing's not intact, well, right now you probably won't be changing that dressing. You need to alert your nurse so they can get it changed. An open IV dressing increases the risk of infection. Anything that would touch the IV or go into the IV should be, done under strict aseptic technique. When someone spikes a new bag, they have to make sure that they keep the spike clean and aseptic, and they don't touch it to something else before it goes in the bag. This is a big one. You need to have the correct fluid and rate. So if the doctor's order says LR and there's D5.5 normal hanging, then do I expect you to go get a bag of LR right now? No, but I expect you to show your instructor and say, hey, according to this order, this is supposed to be LR, but there's D5.5 normal hanging. And the instructor will help you figure out, what's going on or why that is, or if it's indeed an error and we need to change it out. The other issue is rate. You have been taught since fundamentals how to calculate IV drip rates. If you know the rate, which is cc's per hour, and you can tell the drip factor, even if you can't find it on the tubing. If you go in the supply room and you find the same tubing in the supply compartment, all you have to look at is on that package, it'll give you the drip factor. Most of the time, claves are 15. So if you know the rate and you know the drip factor, you can figure out how many drips per minute, and we do expect you to have your correct rate. If you've got a pump, well, your life just got easier. But that doesn't mean you're off the hook. You need to take care of that pump. You need to make sure it's plugged in whenever possible, because how does your cell phone work when your charge gets below 10%? Ever done anything wonky? Ever done anything where you're going, what is my phone doing? Well, it should scare you a little bit that, those IV pumps are also computers. And when they get down below a certain level of charge, they can start behaving very oddly as well. So make sure that you have the correct fluid and rate, know what those different fluids are, and know your math. You should be able to figure out how to come up with those drip rates. I'm not going to give you that information in the clinical setting. That's something that you are expected to already know at this point. Okay, let's talk post-op complications. These are things that usually happen in the first 24 hours but can happen anytime. So the number one complication is hemorrhage. That should not surprise you. Hemorrhage is defined as rapid loss of blood. Now that blood doesn't always have to exit the body. It's just exiting the vascular system. So a person can be bleeding into their abdomen and still be hemorrhaging even though there isn't blood all over the patient's bed. It is the number one complication, and our best defense is a rapid assessment because that helps us to treat it quicker and decreases our problems. So the thing about bleeding, though, is everybody thinks of, checking the dressing, and you're right, we should. But you also, as I mentioned before, need to eyeball those tubes and drains because maybe that blood is being diverted into a drain, and now the drainage coming out of that drain looks completely different in character than it did before. The other thing is, if there's a slight opening in the tape of that dressing and the patient is bleeding, sometimes what will happen is the blood will escape through that tape and it'll actually accumulate behind the patient. So it's, on the bed and you're looking at the dressing and the dressing looks pretty decent, but the patient's bleeding and it's all accumulating underneath the patient. And as I mentioned, bleeding may also be internal, so you may not have any overt signs. You'll have to rely on what you're seeing in the changes of vital signs, their color, their level of consciousness, and potentially things like abdominal distension. Now, signs and symptoms of hemorrhage include shock, and we will be discussing shock here momentarily. Thirst, restlessness. Usually restlessness is actually your first sign. The patient will just be they'll be fidgety. They'll be like, I want to turn over this way, and they go to turn that way, and you can just tell by their face they're still not comfortable. And then they want to turn another way, and you think to yourself, good grief, this person, I can't make them happy. I understand what you're thinking, and I understand that, sometimes that can be frustrating, but get out of that area of thinking and start thinking to yourself, this is restlessness. Why would my patient be restless? Why can't I make them comfortable? And instead of just getting them another pillow like they're requesting, go get everything you need to take a set of vital signs, and then compare those vital signs to their previous vital signs and start doing an assessment for something underlying there, because you might be catching it in its earliest stages if you can recognize those symptoms. Other things, anxiety, abdominal distension, as I said, if they're I can't talk, I've been doing too many videos, bleeding into their abdomen, or a sudden increase in pain, and not the kind of pain that they're used to having, but this will be like a pressure kind of pain, and it's the pain from all of the blood building up. Also, a patient who was able to maybe sit up in the bed before without being dizzy now suddenly is having orthostatic hypotension. They sit up, they start feeling really dizzy. It's because their overall blood volume is diminishing because of the bleeding. So your nursing actions, if you're suspecting any type of excessive bleeding, take a look at that dressing, and you want to get some type of marker or something like an indelible marker that you can write on that dressing, and basically circle where the drainage is, and at the very least write the time. I mean, date is, that would be great, but if this is moving really fast, one, you probably won't have room to write it, and two, the date's going to be understood. Observe your drain outputs, watch your vital signs, and check on your patient frequently. People don't realize that having an immediate post-op patient is a ton more work than having 3 other post-op patients, because this person has that higher risk of all these complications. So you are going to be at a, much more worried, I hope, and trying to keep ahead of any potential complications on that patient. So you're going to be spending a lot of time in that patient's room. All right, so as promised, let's talk about shock. The definition of shock is acute peripheral circulatory failure. Okay, now you can see why we just say shock. Please understand this bullet. Don't memorize it. Don't just hope you'll recognize it. Understand it. The primary sign of shock is hypotension, meaning eventually at some point, to be in shock, someone must be hypotensive. But it's highly unlikely that that's the first sign the patient is going to show you. I mean, if you just think back to your vital signs lecture, usually before your BP drops, your pulse and respirations will go up, right? And then we just talked about the patient being restless. So you might see anxiety and restlessness, tachycardia and tachypnea, all before you really start seeing any blood pressure dropping. And that's because of the body's attempt to compensate for whatever is causing the hypotension. Now, if you remember blood pressure, if you think about blood pressure as an equation. Okay, so write this on the side of your paper. BP equals CO for cardiac output times PVR, peripheral vascular resistance. And the reason I'm having you write that out is just because if I said A equals B plus C, and something affected B and something affected C, it wouldn't be crazy for you to understand that that would affect what A would be. So how does that make sense here? Well, if your cardiac output is impacted, meaning, and cardiac output usually is a combination of stroke volume, meaning the strength of the pump of the heart, and the physical volume of blood that you have, okay? So if something affected the amount of blood that you had in your body and it dropped it, if you just look at that equation, it's really easy to realize, okay, that's going to drop the blood pressure. If you go to the other side of that and talk about the stroke volume, if something affected how well the heart could actually pump, that would impact my cardiac output, and that would impact my blood pressure. Okay, on the other side of that, not the cardiac output side, the PVR, peripheral vascular resistance, we all know that the smaller the tube is that fluid is shoved through, the higher the pressure on the tube. The bigger and fatter the tube is that the fluid's trying to flow through, the less pressure on the tube. So, to increase your peripheral vascular resistance, you want to vasoconstrict. If you vasoconstrict, your blood pressure goes up. Makes sense. Look at the equation. But if something causes you to vasodilate, and suddenly you have this massive amount of vasodilation, then what's going to happen to your blood pressure? It is going to drop. So when you look at this next slide, the way I have done each one of these is we're talking about volume. So that falls in the volume part. The pump is the cardiac output or the stroke volume part. The vessels, those fall in the peripheral vascular resistance. So the first type of shock is hypovolemic. Well, it doesn't take a rocket scientist to realize that that means low volume. So your blood loss blood loss happened maybe in surgery or immediately after surgery, and it's dropping your volume, or that patient was markedly dehydrated for some reason, and that dropped their volume. Any way you slice it, it's going to lead to hypovolemia. So if you look at our equation, that falls under cardiac output, and it falls under actual volume, so there goes our blood pressure, it goes down. The next type of shock is cardiogenic. Cardiogenic means your heart is unable to pump blood with the strength and force necessary to really get it out to the periphery. So again, look at our equation. That impacts the cardiac output part, but this is going to be the stroke volume part. How hard is that heart actually pumping? The next three all fall under vasodilation. Neurogenic shock, anaphylactic shock, and septic shock are all caused for different reasons, but because they cause vasodilation. With neurogenic, the autonomic nervous system is unable to allow your vessels to constrict. So that motor level of the vessel, the tunica media, the muscle layer, can no longer constrict. Since it can't constrict, that means it stays in a state of dilation, and then your blood stays out in your periphery, diminishing what's in your central venous volume, and that's going to drop your blood pressure. With anaphylactic shock, it's because of anaphylaxis. A massive amount of histamine is released. That histamine increases vasodilation and your capillary permeability, meaning that fluid will actually flow out of the capillary at a higher rate. That's why you get swelling and hives. Okay, if the fluid is out there in your sub-Q tissue causing swelling and hives, it's not in your vascular system to be, pushed around by the heart as blood. Last but not least, septic shock. With sepsis, basically, all organisms give off noxious, materials. Humans, we have urine, we have stool, and let's face it, we know that there's some noxious things that come along with that stool. Well, you have to apply that same logic to your bacteria. And if any of you have already taken micro and walked into the micro incubator when you were all trying to grow some funky bug, how did it smell in there? Okay, those fumes and those gases that come off of those bacteria almost behave like, some type of toxin that will, I hate to use the word paralyze, so let's say make the muscle layer less responsive, and so therefore it cannot constrict, and with that it's going to cause the vasodilation. So whether we've got neurogenic, anaphylactic, or septic, it's for three different reasons, but we still have vasodilation. So any way you slice it, this is a vasodilation situation. Now, what are the signs and symptoms of shock? Well, we just said the primary sign of shock is a low blood pressure or hypotension. So it's got to be there. But it might not be the first thing that shows up. That tachycardia or tachypnea or that restlessness that we talk about. If you look most of the way down this slide, it says initially restless. Okay? That's where we'll catch that early. The the tachypnea and the tachycardia, they pretty much come hand in hand. You're going to feel a weak, thready pulse, and then they're going to, have that shallow, quick breathing along with it. The more their blood pressure starts to drop, the more pallor they're going to have. Their skin is going to start feeling cold and clammy because the blood is accumulating out in the skin and it's losing its heat. It's not warmed any longer because it's not coming back to the center. Okay? And then, clearly we said initially restless, but eventually this will lead to lethargy and could even progress to total loss of consciousness if it goes untreated. Another thing that you will see is decreased urine output. As your blood pressure drops, your kidneys are not adequately perfused. If they're not adequately perfused, they can't make urine. So you are not going to get your 30 cc an hour like benchmark that we've talked about, several times at that point. This is not something to memorize. This is just something to kind of give you a quick visual. But you look at the early signs of shock. They're still oriented. They may be a little restless or apprehensive, maybe a little anxious. But if anything, you might see an increased pulse. You might not even see any decrease in blood pressure at this point. Or if you do, it is so minuscule, it is not even something that's going to catch your eye. Then the intermediate signs, we start getting more sensory issues. We start, you'll start seeing their speech being a little slower. Their skin is now going to be clammy and cool. Their breathing is rapid and shallow. Then they're going to start getting pale. The first place they're going to get pale and potentially start to show you signs, circumoral, okay? And then now their pulse is weak and thready, and you probably will see a drop in blood pressure at this point. Hopefully one big enough you'd recognize. Well, obviously advanced signs, this is bad. I mean, look at the little thing in front of blood pressure with a spiraling down. That's terrible. But that's how it happens. If you wait till the advanced stages to pick up on these signs and symptoms, we're going to be in a bucket of trouble. You will remain tachypnic and tachycardic until such time as your heart can no longer keep up with that. And once your heart is deprived of enough oxygen that it can't keep up with that tachypnea, it will go the other direction and that tachycardia, it'll go to bradycardia. And everything will slow down. That's a bad thing. That's not a good thing. That's not them recovering. That's them, getting closer and closer to a really bad outcome. So the treatment of the shock depends on the cause. The general things, obviously, if you think your patient's going into shock, there are definitely things that we can do. Number one thing would be O2. I mean, never deprive your patient of O2. And oxygen is one of those things where we ask for forgiveness instead of permission. I mean, I'm not going to wait for a doctor's order to put O2 on a patient, okay? I can put my patient in Trendelenburg. I can give them, their IV fluids that they already got going. I probably can just increase the rate on those a little bit. I definitely would not give them narcotics, and I would want to keep them warm. But all I can do, you notice all this is supportive. I can't do anything definitive without the physician. The physician's going to need to give me orders. So someone needs to get on the phone and notify that physician so they are aware that we have a problem. Most likely that physician is going to order medications like vasopressors or adrenergics that are going to help us manage this situation. They're probably also going to give us orders for volume expanders rather than just IV fluids, and things that are going to actually turn this around. So hopefully that will, start the process going the other direction. But without notifying the physician, guys, none of that stuff actually gets done. All right, hopefully you don't have too many questions on that, but one of the things I will do when we meet in class is we will talk about shock again and make sure everybody understands what's going on with shock. One thing I also want to say is the only time you don't put your patient in shock in Trendelenburg is if it's cardiogenic shock. So I know what you're thinking. Well, how am I supposed to know what kind of shock it is? It's simple. Since for 4 out of 5 types of shock, you put them in Trendelenburg, put them in Trendelenburg. If they get worse, take them out, because that would probably be cardiogenic. If Trendelenburg actually makes their symptoms worse, then you would take them out of Trendelenburg and just lay them flat. But other than that, Trendelenburg is your friend when your patient's in shock. Okay, let's talk respiratory real quick. Respiratory failure is not the number one concern, because hemorrhage is our number one thing that happens, but it's our number one priority because, let's face it, you don't breathe and pretty much the rest of it is irrelevant. So what increases our risk of some type of respiratory failure post-surgery? Well, the level of consciousness changes. Your patient is in a level of consciousness that is diminished due to whatever medications that we gave them to induce their anesthetic, or maybe their level of consciousness is diminished because of medications we're giving them to manage their pain. But for whatever reason, both of those things can be very impactful. Whether or not you've done a drug card on a narcotic yet for me or for Lisa, or you're not going to do it until you get, to clinical, at this point, having, in process of or in the, finishing pharm, I would expect you to at least have an idea in your head that any opioid that a patient takes can impact their respirations. I would hope that we would all know that at this point, okay? So, have I mentioned that positioning is very important to manage airway? Did I mention that before? Because I think I did. I think it was in bold on another slide, and here we are again. It's in bold on another slide. So clearly, I think positioning is an important way to manage a patient's airway. One of the things that we need to be cognizant of is we need to monitor the patient's response to medications. I don't care if you're not the one giving the patient IV morphine, because of course that would be an RN. If it's your patient, you still have to monitor them for the side effects of that IV morphine, which would be, number one, I know people always want to say, oh, constipation and all that. Yeah, you're right. Those are important later. Right now, if they just gave that IV morphine, what I'm concerned about is their respirations, making sure they're breathing enough and deeply enough to manage their oxygen needs. So if I'm not sure, I can use a pulse oximeter. I can check their respirations just by counting them. But I need to make sure that that patient is adequately perfused and adequately oxygenated. I also want to control nausea. Opiates especially have a pretty significant side effect of causing nausea. One of the reasons they cause nausea is they do drop your blood pressure. And drop in blood pressure can make you feel nauseous. So we oftentimes have to use some type of antiemetic along with that opiate. Like I said before, always have suction readily available. Guys, we're talking about an airway here, so we need to make sure that's going to be managed. Okay, this seems like another good place to stop off, so I will stop here, and we have, I believe, one more lecture to go.